Coronavirus has a strong impact on administration of cellular therapy at different levels, depending on which type of cellular therapy we are talking about. So if we consider hematopoietic stem cell transplantation, whether autologous or allogeneic, the supply chain has been strongly disrupted for the procurement of allogeneic cell grafts, in particular from unrelated donors, because these cell products have to cross borders on many occasions, and borders have been closed within Europe and outside Europe. And the courtier who carries the cell transplants really have a hard time to get the graft to the transplant center. So that's one aspect. Another very important aspect is that transplant patients, recipients, whether of autologous or allogeneic transplants, are relatively fragile, frail patients because they combine the immune suppression that is usually associated with hematological malignancies, the immune suppression induced by prior treatments, induction chemotherapy, salvage chemotherapy, and the immune suppression that is associated with stem cell transplant, whether autologous or allogeneic. So there are many recommendations from national professional associations, EBMT, ASTCT, and so on, and regulatory bodies that recommend to delay or postpone autologous transplantation or allogenic transplantation whenever this is possible. When this is not possible, there are recommendations to isolate and test both donors and recipients in order to ensure the highest level of safety. An important aspect is that on many occasions, stem cell transplantation is a consolidation treatment for a tumor response that has been previously induced, which leaves some flexibility to postpone or delay the transplantation. And this is where it is very different from CAR T cells, for example, because CAR T cells are indicated for refractory or relapsed patients. So in those circumstances, there is little flexibility to postpone the treatment. And these patients may actually require to be transferred on the ICU if post-treatment complications such as CRS or ICANS appear. So treating physicians have to carefully assess the usefulness of the treatment and discuss with the physicians on the ICU whether this is feasible to transfer a patient to the ICU if it's needed. So, on the contrary, the supply chain for CAR T cells seems, at least at the moment, and the situation is evolving fast, so nobody knows how things will be tomorrow or after tomorrow, but at least as of today, the supply chain for CAR T cells seems to be intact, and it is actually still possible to ship primary cells to the central manufacturing organization so that the medicinal product can be manufactured, and to receive the CAR T cells when they have been released from the central manufacturing organization. So getting the cells to the treatment is more difficult in the transplant field than it is in the CAR T field, but management of the patients may be somewhat more tricky in the CAR T field than it is in the transplant field. But again, it's really a case-by-case basis, and one needs to carefully assess each patient, each potential recipient, for the risk-benefit ratio when deciding to deliver or not transplant or cellular therapy.